Welcome to MedEd 360. Today, we'll dive into a critical pediatric case, a 7-month-old baby girl with fever and a rash. From diagnosis to detailed discussions on its prevention, treatment, and complications, we'll cover everything you need to know about one of the most contagious diseases in history. Stay tuned for expert insights based on WHO and CDC guidelines. Let's dive in. Meet Fatima, a 7-month-old infant, is brought to the clinic with fever of 39 degrees Celsius for 4 days. Fever is associated with irritability and poor oral intake. Her parents noticed red spots behind her ears 2 days ago, which spread to her face, trunk, and limbs. She has cough, coryza, conjunctivitis, and mild photophobia. She has not been vaccinated, and her diet is mostly cow's milk with minimal complementary feeding. Recently, her parents and Fatima attended a wedding where multiple children were sick. On physical examination, she appears irritable, mildly dehydrated, and on nutritional status, she has mild wasting and pallor. She has conjunctival injection with mild photophobia. She has temperature of 39 degrees Celsius, pulse of 120 beats per minute. Her respiratory rate is 30 per minute. She has a diffuse erythematous maculopapular rash at the hairline, behind ears, and spreading downward towards trunk and limbs. In oral cavity, she has small, white, sandalgri-like lesions on buccal mucosa known as Koplik spots. On respiratory examination, she has mild rhonchi, no crepitations. Her laboratory tests were done. Her complete blood count revealed lymphocytosis with mild leukopenia, hemoglobin of 10 gram per deciliter, mild anemia, platelets 200,000 per microliter, normal. Serology revealed measles-specific IgM antibodies was positive. Urinalysis was unremarkable. So, what do you think is the diagnosis in this case? Pause the video and comment your answer and give your reasoning for it. What gave away the diagnosis? Based on all the information available, the clinical diagnosis is of measles that is confirmed by the presence of Koplik spots, the characteristic erythematous maculopapular rash, and positive IgM antibodies against measles virus. Now, we will dig deeper into the contagious world of measles. We will try to be as comprehensive as possible so that you guys don't need to go through any other source for it. Let's begin. Measles, also known as rubeola, 10-day measles, or red measles, is an acute viral respiratory disease caused by the measles virus, a single-stranded, negative-sense-enveloped RNA virus. It is classified as a member of the genus Morbillivirus in the Paramyxoviridae family. Humans are the only natural hosts of measles virus. In the 9th century, a Persian doctor published one of the first written accounts of measles disease. Francis Home, a Scottish physician, demonstrated in 1757 that measles is caused by an infectious agent in the blood of patients. In 1912, measles became a nationally notifiable disease in the United States, requiring U.S. healthcare providers and laboratories to report all diagnosed cases. In the first decade of reporting, an average of 6,000 measles-related deaths were reported each year. A vaccine became available in 1963. In the decade before, nearly all children got measles by the time they were 15 years old. In 1954, John F. Enders and Dr. Thomas E. Peebles collected blood samples from several ill students during a measles outbreak in Boston, Massachusetts. They wanted to isolate the measles virus in the students' blood and create a measles vaccine. They succeeded in isolating measles in 13-year-old David Edmonston's blood. In 1963, John Enders and colleagues transformed their Edmonston B strain of measles virus into a vaccine and licensed it in the United States. In 1968, an improved and even weaker measles vaccine, developed by Maurice Hillman and colleagues, began to be distributed. This vaccine, called the Edmonston-Enders, formerly Moritin, strain, has been the only measles vaccine used in the United States since 1968. Nowadays, the measles vaccine is usually combined with mumps and rubella, MMR, or combined with mumps, rubella, and varicella, MMRV. In 1978, CDC set a goal to eliminate measles from the United States by 1982. Although this goal was not met, widespread use of measles vaccine drastically reduced the disease rates. By 1981, the number of reported measles cases was 80% less compared with the previous year. However, in 1989, measles outbreaks among vaccinated school-aged children prompted the Advisory Committee on Immunization Practices, ACIP, the American Academy of Pediatrics, AAP, and the American Academy of Family Physicians, AFB, to recommend a second dose of MMR vaccine for all children. Following widespread implementation of this recommendation and improvements in first-dose MMR vaccine coverage, reported measles cases declined even more. In an historic achievement, measles was declared eliminated from the United States in 2000. This meant the absence of the continuous spread of disease was greater than 12 months. This was thanks to a highly effective vaccination program in the United States, as well as better measles control in the Americas region. This was a brief and fascinating history of the world's most contagious disease that have taken so many lives. This was also important for the fact if one county can eliminate measles, why not all the other countries? By educating people and by applying strict comprehensive vaccination programs by the government, it can be eliminated in other countries as well. Now, let's learn more about measles. The mode of transmission of measles is airborne via respiratory droplets or by direct contact with nasal or throat secretions. The virus remains active in the air or on surfaces for up to 2 hours. R0, which stands for basic reproductive number, is 12 to 18 and is considered one of the most contagious diseases. R0, basic reproductive number, refers to the average number of secondary infections caused by one infected individual in a fully susceptible population. It is a measure of how contagious an infectious disease is. For measles, an R0 of 12 to 18 means that one person with measles can infect 12 to 18 others if no one in the population has immunity through vaccination or prior infection. This extremely high basic reproductive number makes measles one of the most contagious diseases known. The factors contributing to this high R0 include airborne transmission, high viral load and shedding, and susceptibility of unvaccinated individuals. Let's talk about each factor. Number 1. Airborne transmission. Measles can spread through respiratory droplets and remains viable in the air or on surfaces for up to 2 hours. Number 2. High viral load and shedding. Infected individuals shed large amounts of the virus even before symptoms become apparent. Number 3. Susceptibility of unvaccinated individuals. Without vaccination, nearly everyone exposed to the virus is likely to get infected. For comparison, other diseases have much lower R0 values, such as seasonal influenza, 1.5 to 2, or COVID virus, generally 2 to 8. Another concept is that of R effective. Vaccination dramatically reduces the effective reproductive number that is R effective because immunity in the population, herd immunity, prevents the virus from spreading freely. Now, we'll discuss in detail about R0 and R effective because these concepts are very important for understanding infectious disease epidemiology, resulting in how vaccination in the community works for measles. R0, that is, basic reproductive number, is the average number of secondary infections caused by one infected individual in a completely susceptible population that has no immunity or no interventions like vaccines or treatment. R0 is a fixed value for a given disease under ideal conditions, reflecting the intrinsic transmissibility of a disease. Now, what is R effective? R effective is effective reproductive number. It is the average number of secondary infections caused by one infected individual in a population where some individuals may already be immune or vaccinated, or where control measures, e.g., masks, isolation, are in place. R effective is a variable value, as it depends on the current level of immunity and interventions. For example, R effective is equal to the product of R0 and fraction of the population still susceptible. Let me explain it by an example. If 90% of a population is immune to measles due to vaccination, the R effective will drop significantly because fewer individuals can become infected. This concept was seen during a lockdown for COVID-19 infection, where R effective dropped below 1 because of widespread use of masks, isolation, and quarantine measures, leading ultimately to a decline in cases. Let's summarize what we have learned so far. R0 describes the potential for spread in a naive population, theoretical maximum, while R effective describes the real-time spread in a population considering immunity and interventions. Why all this matters? This is because public health efforts aim to reduce R effective to below 1 to stop outbreaks. In summary, are not as static and theoretical, while our effective is dynamic and practical, reflecting real-world conditions. Now let's talk about the clinical side of measles. The incubation period of measles is about 7 to 14 days from exposure to symptom onset. The rash onset typically occurs 7 to 14 days after exposure and lasts for about 4 to 7 days. The World Health Organization has developed a diagnostic criteria for measles, in which there are 3 distinct stages. These stages are a prodromal stage, exanthem stage, and lastly a recovery stage. The prodromal stage lasts for about 2 to 4 days. In this stage, patient has high fever, usually more than 38.5 degrees Celsius. Patient may also have what is known as 3 C's of measles that are cough, coryza, conjunctivitis. Coryza simply means runny nose, like flu. In the prodromal stage, the patient has the characteristic Koplik spots, which are sand grain-like spots in the oral cavity on buccal mucosa. Koplik spots appear 1 to 2 days before appearance of the rash. After the prodromal stages comes the exanthem stage, usually from day 4 to day 7. In this stage, a maculopapular rash starts on the face, on hairline, and also behind the ears. The rash then spreads to the trunk and extremities. This rash fades in the same order, in about 4 to 7 days, leaving brownish discoloration. Lastly, the recovery stage, in which there is gradual resolution of rash and fever. Another very important thing to know is the infectious period of measles. This is the period of time when an infected person can spread the virus to others. This period typically lasts from 4 days before the rash appears and 4 days after the rash appears. So the total infectious duration is approximately 8 days, beginning before the visible rash and ending when the rash starts to subside. During this infectious period, the virus is highly contagious, especially in areas with close contact, like households, schools, or healthcare settings. Measles spreads through respiratory droplets and can remain infectious in the air or on surfaces for up to 2 hours after an infected person has left the area. When is the peak infectiousness? Infectiousness is at its peak just before and shortly after the rash onset, as viral loads are highest during this phase. This understanding of the infectious period is crucial for identifying close contacts for quarantine or post-exposure prophylaxis, and also for implementing infection control measures, such as isolation. Now let's discuss the complications of measles. These are more severe in malnourished and immunocompromised children. These complications are as follows: pneumonia, which is the most common cause of death in measles; croup or bronchiolitis; acute disseminated encephalomyelitis, ADEM; subacute sclerosing panencephalitis, SSP. It is a rare, fatal complication occurring years after infection. A few points about SSPE. It generally develops 7 to 10 years after a person has measles, even though the person seems to have fully recovered from the illness. The risk of developing SSP may be higher for a person who gets measles before they are 2 years of age. Symptoms of SSP occur in 4 general stages. With each stage, the symptoms are worse than the stage before. In stage 1, there may be personality changes, mood swings, or depression. Fever and headache may also be present. This stage may last up to 6 months. In stage 2, there may be uncontrolled movement problems, including jerking and muscle spasms. Other symptoms that may occur in this stage are loss of vision, dementia, and seizures. In stage 3, jerking movements are replaced by writhing, twisting, movements, and rigidity. Death may occur from complications. In stage 4, areas of the brain that control breathing, heart rate, and blood pressure are damaged. This leads to coma and then death. Some other complications of measles are otitis media, severe diarrhea leading to dehydration, corneal ulceration, and blindness, especially in vitamin A deficiency. If you are still here learning about measles, kindly give it a thumbs up and share it with friends, family, and colleagues, so that they can also get this very useful information about a very common disease. And if you're interested in more videos like this, please subscribe to my channel and comment below for any topic you want me to cover next. Let's resume our topic. Okay, so how do we diagnose measles? It is mostly a clinical diagnosis. The presence of fever, Koplik spots, and characteristic rash, its appearance, timing, and distribution are enough to diagnose measles. However, we can also perform some investigations as well. Like, we can do serological tests, in which we can find IgM antibodies against measles virus. They appear 3 days after rash onset, persist for 30 days. In places where available, reverse transcriptase polymerase chain reaction, or RT-PCR, can also be done, in which molecular detection of viral RNA is done in blood samples or throat swabs. What about treatment? There is no cure for measles. Treatment is mainly supportive, with hydration with oral or intravenous fluids to correct dehydration, paracetamol or NSAIDs for fever. Nutritional support in the form of adequate calorie intake is also an important component of treatment. Something unique to measles is the requirement of vitamin A supplementation. As per the WHO guidelines, the recommended dose of vitamin A in measles is as follows: 50,000 international units orally for 2 days in infants less than 6 months, 100,000 international units orally for 2 days in infants 6 to 11 months, 200,000 international units orally for 2 days in a child of 12 months or more. Vitamin A is important because it reduces the risk of blindness and mortality. Few points on management of complications. Pneumonia and otitis media are treated with antibiotics. Severe diarrhea is managed with oral rehydration solutions and zinc supplementation. If severe dehydration, intravenous fluids are given. In encephalitis, the patient needs intensive unit care with anticonvulsants as needed. We are almost at the end, and the most important aspect of measles, that is the measles immunization. The best way to protect against measles is to get the measles, mumps, and rubella (MMR) vaccine. Children may get the measles, mumps, rubella, and varicella (MMRV) vaccine instead, which protects against chickenpox too. MMR and MMRV vaccines usually protect people for life against measles and rubella, but immunity against mumps may decrease over time. First dose of MMR vaccine is given at 9 to 12 months of age, and the second dose MMR vaccine is given at 15 to 18 months of age or before school entry. Vaccine against measles is very effective. Single dose has 93% efficacy, while 2 doses have 97% efficacy. Post-exposure prophylaxis is recommended for individuals who are not immune to measles when they come in contact with a patient of measles. Post-exposure prophylaxis is done by measles vaccine, given within 72 hours of exposure. By doing so, you may get some protection or have milder illness. Post-exposure prophylaxis is also done by immune globulin, given within 6 days for high-risk groups including infants less than 6 months, pregnant women, immunocompromised. This may provide some protection or milder disease. The recommended dose for intramuscular immunoglobulin is 0.5 milliliters per kilogram, regardless of the contact's immune status. Another very important point to consider is that don't administer MMR vaccine and immune globulin simultaneously. This practice invalidates the vaccine. Apart from the immunization program, measles vaccine should be considered for specific groups who do not have evidence of immunity against measles, including college students, international travelers, healthcare personnel, close contacts of immunocompromised people, people with HIV infection, adults who got inactivated measles vaccine, groups at increased risk during measles outbreak. Thank you for watching this video. This topic holds a very personal significance to me, as my own son battled measles and experienced severe complications. Witnessing his struggle firsthand inspired me to create this video to raise awareness and help others understand the seriousness of this disease. I hope this case and discussion provided you with valuable insights into recognizing, managing, and preventing measles. If this video helped you, or if you have similar experiences to share, let us know in the comments. I'd love to hear from you. Don't forget to like, subscribe, and share this video to spread knowledge and protect more lives. Together, we can work towards better health for everyone. See you next time on MedEd 360.